Hello. We're really excited to be here today, and I guess I'm really excited, particularly to be able to say I'm happy to be here to talk about mental health.
Indeed, we are.
So a little bit about us. My name is Bateman. I am the head of mental health services for Home Care Medical, which delivers the National Telehealth Service. And the apple is because I'm originally from New York. Don't be fooled by the accent. I'm not Canadian. And so that gives a little bit of a different perspective sometimes for me.
It does indeed. And I'm Sharryn, and I'm from the Big Coat Hanger. I'm from Sydney. I've been working with Home Care Medical, who provide the National Telehealth Service for the last year and a half. I'm very excited to be here with Anne to talk about what we're doing in mental health, a very important piece of work that's happening in New Zealand. Go on, Anne.
So in mental health, I always like to start with the people that we're serving. So this is a little bit about some of the people who are calling us, who are getting a health response that is delivered to them versus an emergency response. I'm going to leave this, and we'll come back to it towards the end. So our service is about supporting Kiwis to be connected to care. Today we're going to talk about the mental health nurses, but the National Telehealth Service was really established to create a platform to give capacity and capability within the New Zealand health sector. We're a social enterprise, and so we are highly invested in making sure that we are doing continuously better and continuously innovating to do better for Kiwis.
So the earlier mental health response that we're going to talk about this afternoon was funded by Treasury. It commenced in 2017 on the virtual platform that's been built for the National Telehealth Service. The service is now nationwide, and the initiative is a well-joined-up initiative of police, Ministry of Health, ambulance services across New Zealand, and of course our own organisation, Home Care Medical.
In order to deliver a health response to mental health crisis callers, 3 components were established. The first is a mental health triage system, and so this is about doing that core triage work. Building system capacity is also something that's really important within this response system, and the expert advice line was designed to build capacity within the professional community. The National Directory is the part that sits underneath, and this is about people coming through the different services and then being connected into the mental health systems of care. This is demonstrative of some of the early work that was done projecting how this program could make a difference to Kiwis who are encountering mental health crisis. So as you can, the main point of this is really to show before we had a dispatch and no dispatch option, and now we have the triage and the delivery into the mental health system of care or into a self-care model. And we'll talk a little bit more about how that actually works. Part of our core, part of the fabric of what we do is co-design. And so this is about including the people who will be using the service day to day. So this co-design process incorporated people who are experienced in having mental health crises, who are mental health service users, as well as police and ambulance. This was about designing and delivering a different way to care for people. These are some of the pictures from the co-design, which are really, it's an active process and it's an involved process, and people still, a couple of years later, talk about how energizing this was to be a part of. So the basic way that people move through the system, and I'm sure all of you have experienced people who are in mental health crisis of some sort, is that as people come in through emergency services, the operator identifies them as being in mental health distress. And now these are people who don't necessarily need a call out, but they do need care. So the operator then connects them into,
And there's no emergency.
And there's no immediate, this is the part where there's no immediate call out needed. So this connection point is really one of our keys. Marrying these two different disciplines and doing the handover process smoothly and safely, sensitive to the consumer's needs and to the different people involved, is a really important part of this process. What we heard in the co-design from people was that if they called, they're in crisis, often they're floridly psychotic, right? So people are calling and they're saying, you know, my cat's stuck in a couch. And maybe they don't actually have a cat, but what they would like is for the ambulance or the police operator to say to the mental health nurse, look, their cat is stuck in the couch. And they would like some help with that. And because we have mental health nurses, they understand what this means. And so they can receive that person and work through what is actually happening. Now, if your cat's stuck in the couch, but you don't actually have a cat that can be stuck in the couch, and you think that cat might be exhibiting some mind control tendencies, we can take care of that person well, right? And often those people are, they're going to be the people frequently calling emergency services because this is a recurring distress. So at this point, our mental health nurses, they're doing a triage, and they're going to do that triage and assess that person's level of need. They use the UK triage scale, and then that tool gives indication of where they need to go. Often, because we are dealing with people who are known to services, often we know them, and we also can have something in place that will guide us in that decision-making process and in that caring process. So this is what we see. When we started this, the DHB Secondary Services said to us, what are you going to do? You're going to push all kinds of volumes into our services, and we certainly don't have funding to handle all those people. And we said, you know, let's stay joined up, let's work together, and let's see what happens. And actually, what we found happens is that a lot of people need information and advice, and they are able to do some self-care. Often they already have plans in place that they're able to follow those plans. We de-escalate. And that some people are connected into the DHB mental health services, the secondary services, or they're connected back into their GPs. Often those people are already known clients. A small percentage are returned back to secondary or to emergency services, but it's a very small percentage that come back. The main point of this, I won't go through all the different sections and all the different parts, is that we are getting a lot of calls, but that public access line is the little magic part of it. So this public access line is the number for those people who are calling sometimes several times a day, frequently, that they can reach us directly, that they don't necessarily need to be going through 111. So if they are known to us, they're frequently coming to us, they have this number. It's not a publicly available number, it's a number that they're able to have and contact us directly.
So who are we helping? We're helping pretty much 50-50% equal male and female. That's what the data's showing us. We know that the age 20 to 29 is a very active age, and that cohort of people are out and about, and they may be more likely to get in trouble with their mental health concerns, and so they are the largest volume. And we also know that, as one probably making an assumption would expect, the people over 75 are less frequent people calling emergency services because they're possibly more likely to be tucked up at home and not out and about. The ethnicity breakdown, though, is very important. We know that, and we heard Lance O'Sullivan yesterday talking about the prevalence of mental illness and health disparity of care for the Maori population in New Zealand. And what we find here is that we have a higher than the prevalence rate of people using this service, or us delivering services through this, this line, which is great. So we're very pleased with that. But we put in place as part of the project some things that we thought were success factors, and they fit under some three sections: co-governance, integrated service delivery, and clinically led services. And we've built on that over time. And I think that Anne and I, well, we both agree that these are continued success factors. This is what is keeping this service operating fantastically well and keeping our service users really, really safe. So we have our co-governance with the Ministry of Health through commissioning and through the Director of Mental Health, the NASO, the National Ambulance, I'm sorry, I'm going to say the wrong service office. I've got that wrong, NASO, the police and home care medical all combined in a governance framework. We provide integrated service delivery, and Anne will speak a little bit about the DHBs in a minute, and the clinically led services that sits under the remit of the clinical director, putting in place great experience for our service users and for our staff. So Anne, do you want to talk about the sector relationships?
One of the core things is about connecting into the sector and making sure that as people are coming through these different services that they are tended to well. What we really try to do is we try to match up. So we match our mental health leadership, we match our operational management, and we match our clinical service delivery so that we have a tightly bound together system of care. No small feat with 20 DHBs. And it is an ongoing work in progress, and I'm sure we have a lot of areas we can improve in, but it's really been part of what guarantees a combined service delivery.
Successfully. Good. Okay. So the clinical model, our staffing is very important to us. We have around 28 registered mental health nurses, all New Zealand based, all with many, many decades of experience between them. They operate the service 24/7, so there's always someone there to receive calls. As I said, the amount of experience, I was in a meeting with 4 of them the other day and we added up that there was 162 years of experience between 4 nurses, so it's pretty substantial. And these people have come from backgrounds of management, of leadership, clinical leadership, great team of people to have. They, and many of them as well, have worked internationally in similar, or not similar, but in services providing primary and secondary mental health care. The home care model is that people work in a virtual environment. So whatever service line you're part of, you could be anywhere in the country on one platform, which is fantastic and solid and robust. And a lot of our staff in this line work from home. So they can be sitting at home or in their home office, delivering care to the people, but sitting on the same platform as someone who's working in say, our Auckland or our Christchurch contact centre. We have robust clinical information systems, so the platform that's been built is reliable, stable, data secure. We have really good clinical decision support tools and fabulous toolkit for our mental health clinicians to be accessing. Our team roster structure is designed so that there's inbuilt pathways for any clinician at any time to access support from another team member. This can be done by instant messaging, can be done by a phone call, and it's very collaborative and provides a great security for anyone calling to know, well, we know that anyone that calls, if there's extra help needed, that is always available at hand. We have strong and effective clinical leadership through the management structure. So at the top of that team is, under Anne's responsibility, is a service delivery manager who has amazing depth and calibre of experience, and team managers who also have great experience in management of mental health services, and then the general clinicians working there. The team is supported by the usual things that one would expect, so team meetings, service review, those sorts of things, as well as both in-house and external supervision, which is fantastic for them. Our continuous clinical quality assurance is the same as it is right across all of home care medical, so it's very, very strong. We are an ISO 9001 accredited business. And for the clinical assurance, because we're a contact centre environment, we're taking phone calls and text messages and all sorts of communications from people. We have a process of reviewing those interactions, both on a regular process, regular basis, as a routine part of what needs to happen for assurance, but also by exception when necessary. We have a very strong feedback management process. So if someone does make a complaint, and of course, like any healthcare business, there will be complaints. Someone makes a compliment, and fortunately we get pretty much equal compliments as complaints right across our whole business. Or if we identify something that's gone wrong ourselves, which we call an incident, that process that's of assurance, of review, of checking and putting in checks and balances continues right around the clock, and we make sure that things continue to improve. Our policy and procedure development and review is also very robust, and what was really great about the co-design and the other co-design work we've done subsequently, like for our 1737 service or our Safe to Talk service, where we co-design with service users, means that the development of those initial protocols and procedures takes into account the way that service users want us to work with them, and so I think that's a great initiative. Our staff are supported with continuous learning and development. People attend conferences, people attend courses, people can do their own research and get support and whatever for that. And we also have a internal audit procedure so that we do make sure that things are going well pretty much all the time. So that's how we manage our clinical quality assurance. So Anne, back to you now.
So one of the system impacts of this service is that we are reducing the number of ambulance and police call-outs. And that's a really significant system impact. But why we get out of bed every day is really because of this. Because these are two people who got a response, they got a ready response, they got a quick response, and then they got mental health care. So they were able to then access services, they were able to start on a road to recovery and a journey to recovery that might have taken a slightly different path had they had a police call out, had they had an ambulance arrive. That would have gotten them there eventually, but that reduction on the system burden and then the quick response to a mental health concern is part of what drives this service and part of what gets me out of bed every day. So.
Thank you.
Thank you.